At this time, all participants are in a listen-only mode. During the question and answer session, please press star 1 on your touch-tone phone. Today's conference is being recorded. If you have any objections, you may disconnect at this time. And now I would like to turn the meeting over to Barbara Easterling. You may begin.
Thank you. Good afternoon. I am Barbara Easterling from HRSA's Office of Quality and Data within the Bureau of Primary Health Care. Thank you for joining us for this audio conference entitled Safeguarding the Future, Reducing Obstetric Liability Risk. Here at HRSA, we continue to listen to your feedback and suggestions on risk management, quality, and accreditation needs. Today with us, we have our partners, Keystone Peer Review, also known as KEPRO, and the ECRI Institute, who look forward to meeting your risk management needs by providing topics that will enable you to enhance your provision of services. I will now turn the presentation over to Amy Goldberg-Alberts, Program Director for the ECRI Institute, who will lead us through the broadcast. At the end of the broadcast, we will be able to answer your questions about this topic. Thank you again for joining us.
Thank you, Barbara, and thank you everyone for attending. I'm Amy Goldberg-Alberts, Director of the Program of Clinical Risk Management Resources, provided on behalf of HRSA here at ECRI Institute. I'll begin with a couple of words about KEPRO, a quality improvement and care management organization founded in 1985 and headquartered in Harrisburg, Pennsylvania. KEPRO selected ECRI Institute to provide you free clinical risk management resources. KEPRO works with HRSA on medical malpractice claims reviews and risk management services under a contract initiated in 2004 and provides risk management and patient safety technical assistance to Section 330 FTCA deemed health centers and free clinics. ECRI Institute, an independent nonprofit applied research institute, over the past 4 decades has helped thousands of healthcare organizations across the nation develop patient safety, healthcare quality, and risk management programs to improve patient care. Over half of all of the HRSA grantee organizations throughout the country have now activated their user IDs and have set up passwords so that they can access the full suite of clinical risk management resources being made available by ECRI Institute to you free on behalf of HRSA. This website contains risk management guidance articles, sample policies and procedures, risk assessment tools, educational courses with CME credit, and other resources to make your jobs easier so that you can learn from others, so that you can customize materials to your own organization's needs and not have to reinvent the wheel. You can read about all of the resources offered, and you can log in from www.ecri.org/clinical_RM_program. With your audio conference registration confirmation, you received an email link to the slide handout. We hope that you've had the opportunity to print or download the handout. If for any reason you do not have it in front of you, it's also available now by going to www.ecri.org/clinical_RM_program. You do not need a password in order to download the handout. Once more, that address is www.ecri.org/clinical_RM_program. Throughout this audio conference, we will refer to slide numbers in the handout so that you can follow along. This is our 6th in a series of brown bag lunch audio conferences, all of which are archived on the website if you missed them live. I'm pleased now to introduce our speakers for today's program. Madeline Quattrone and Kathy Shostak will be our speakers. Before joining ECRI Institute in 1999 as a senior risk management analyst, Madeline was a board-certified civil trial attorney. She has nearly 20 years' experience defending physicians, nurses, hospitals, and other healthcare providers. Her extensive trial experience includes the defense of obstetricians, certified nurse midwives, obstetrics nurses, and hospitals in cases involving brain-damaged infants. At ECRI Institute, Madeline is a senior risk management analyst, and she serves as legal editor of risk management publications. For those of you on our previous audio conferences, you already are familiar with Kathy's experience in ambulatory care risk management. Kathy is a nurse with 20 years of experience in healthcare risk management, the most recent of which have been focused on patient safety and medical error prevention. She has risk management consultative experience within the medical malpractice insurance industry and management experience at the corporate risk management level of a large multi-specialty physician group. Ms. Shostak serves as ECRI Institute's Chief Risk Management and Patient Safety Liaison to the HRSA-funded health centers and free clinics. With that, I will first hand the program over to Madeline.
Thank you, Amy, and welcome everyone. Slide 4 contains the objectives for today's audio conference. In order to lay the foundation for today's program, we'll first provide some background information on the magnitude of the risks involved in obstetrical practice by reviewing malpractice claims frequency and severity. Then we'll look at common high-risk areas in obstetrical practice and review ways to reduce risks, drawing from successful perinatal safety initiatives and addressing important informed consent issues. Throughout this program, we will refer to resources available at the Clinical Risk Management website that are available to help you address the risks in your obstetrical practice. On slide 5, we see that 91% of obstetricians have been sued for professional negligence, according to the results of 2009 ACOG survey on professional liability. Claims experience also begins early in obstetricians' careers. 43% of respondents to this survey reported at least one claim arising from their residency experience. A report just released from the American Medical Association's 2007-2008 Physician Practice Information Survey of 5,825 physicians across 42 specialties revealed that the number of claims per 100 physicians was more than 5 times greater for general surgeons and obstetrician gynecologists than it was for other specialists such as pediatricians and psychiatrists. Obstetric cases are also among the highest in damage awards of all specialties. Among examples are a $100 million damage award in year 2000 by a Philadelphia, Pennsylvania jury, a $60.5 million Florida verdict in 2008, and a $38.5 million verdict in 2009 in Connecticut. These astronomical verdicts were awarded in obstetrical cases involving severely impaired infants. On slide 6, we see a summary of a claims study by the Physician Insurers Association of America, or PIAA. This report from PIAA Data Sharing Project noted more than 5,400 cesarean section closed claims between the years 1985 and 2009. Among these claims, 38% were paid, with an average indemnity of $541,883. That's $2009. PIAA reviewed claims in 12-year increments and found a 21% decline in the number or frequency of claims. But over that same period, the average indemnity payment, that is, monies paid to claimants, increased by 29%. So although the number of claims dropped, the claims severity increased. Moving to slide 7, nearly half of the claims for brain-damaged infants resulted in payment. Compensation for a brain-damaged infant may include an award for pain and suffering, past, present, and future medical expenses for lifelong care, loss of potential income, and hedonic damages, that is, loss of enjoyment of life, in jurisdictions where this legal cause of action is recognized. Parents may recover damages for their emotional distress where the facts and circumstances warrant so under applicable state law. Plaintiffs typically present evidence to support their damage claims with testimony and evidence provided by forensic economic expert witnesses and/or nursing and rehabilitation professionals. Typically, a trial will involve some display or brief presentation of the injured child during the trial. For example, a brain-injured child, for example, maybe 4 years old, may be brought into a courtroom in a wheelchair to allow the judge or jury to see the child. In addition, plaintiff's attorneys typically present as evidence of damages a carefully edited day-in-the-life video that illustrates the child's daily struggles and challenges, as well as the parents' efforts to care for the disabled child around the clock. KEPRO's Medical Review and Risk Analysis Summary for HRSA fiscal year 2009 lists obstetrics-related incidents on slide 8 as the most costly category resulting in malpractice claims. Costs are represented by the line graph and noted as the highest point on the line. So although diagnosis-related incidents are more frequent, as noted by the bar graphs, obstetrics presents the highest risk in terms of cost or severity. And when we are concentrating on risk reduction, severity should always be the primary focus. On slide 9 is an example of a high-severity case involving allegations of negligence during childbirth that reportedly resulted in the infant experiencing quadriplegia. In their lawsuit brought under the Federal Tort Claims Act, the plaintiffs alleged negligence against the involved obstetricians, pediatricians, obstetrical and pediatric nurses, and the hospital. They alleged that the defendants failed to properly assess and treat the mother, who was admitted with unknown Group B strep status. They also alleged that the defendants failed to follow up and convey information to other members of the healthcare team about the need to follow up on testing for Group B strep during the antenatal period, and failed to order antibiotics when the pregnant patient presented with unknown GBS status, and further failed to recognize and respond to the mother's risk of infection as a result of suspected prolonged rupture of the membranes, and that the nurses failed to advocate on behalf of the mother. The plaintiffs further alleged that the defendants failed to follow the chain of command when a physician did not timely respond to the nurse's request to come to the hospital. There were additional allegations of negligence against the pediatrician and nurses that related to delay in diagnosis and treatment. After a week-long trial before a federal judge sitting without a jury, judgment was entered for $22.6 million to be paid by the federal government on behalf of the physicians involved. That damage award was in addition to a previous $6.5 million out-of-court settlement that was reached with the hospital before trial. On slide 10 are the 3 highest risk areas reported by PIAA for claims related to common obstetrics practices. Cumulative data from PIAA closed claims from 1985 through 2007 shows that the claims associated with cesarean section delivery were the most prevalent and resulted in the highest average and highest total indemnity payments. While these statistics generally refer to delays in responding to fetal distress and or delays in performing cesarean sections resulting in infant brain damage, it should be noted that the current rate of cesarean deliveries at over 30% in the United States is also a cause for concern. We will address this further a little later in the program. Forceps deliveries were associated with significantly fewer claims, but more than half the forceps delivery claims and lawsuits resulted in indemnity payment. Nearly half of all claims involving a brain-damaged infant closed with an indemnity payment, and for claims closed in 2007, the claims that involved brain-damaged infants had the highest average indemnity payment, totaling more than $688,000. Shoulder dystocia was the 3rd most frequent patient condition associated with claims closed by PIAA in 2007. 45% of these claims resulted in an indemnity payment averaging nearly $453,000. In PIAA's cumulative analysis of claims involving obstetric and gynecological surgery, the associated issues listed on slide 11 rose to the top in terms of frequency. In just a few minutes, I will discuss informed consent and review the latest recommendations by the American Congress of Obstetricians and Gynecology's Committee on Ethics, Statement on Informed Consent, released in August 2009. The legal concept of vicarious liability, when it applies, assigns legal responsibility for the wrongdoing of one individual to another individual, depending on the facts, circumstances, and state law. For example, a physician who directs a nurse to act in a manner that violates facility policy might be held vicariously liable if the nurse's action is found to have been negligent. And so, obstetrical providers need to be concerned about the following issues: supervision, chain of command, and communication among the obstetrical team, and clearly defining the roles and responsibility of ancillary care providers. Fetal demise and other adverse outcomes have been associated with failure to obtain and remain aware of a patient's full medical and obstetrics history, and or failure to conduct a careful evaluation of the patient's medical and non-medical risk factors for adverse outcome. Communication failures among providers and inadequate documentation also amplify the risk to the patient. During the difficult labor, members of the obstetrics team should resolve any differences of opinion among themselves about the patient's proposed plan of care and resolve team differences regarding their opinions out of the hearing range of the patient or family members. It cannot be overemphasized that communication failures may directly result in patient injury, and poor communication between provider and patient results in patient dissatisfaction and motivates litigation. For example, recent studies show that physicians often don't realize that they are not on the same page as the patient. A simple way to find out is to ask the patient to repeat to you, in her words, what she has been told. Slide 12 reviews informed consent issues and obstetrics GYN claims. That so many informed consent claims result in a verdict or other payment demonstrates that these claims are not frivolous. ACOG, for example, in its recent statement, states that informed consent is an ethics issue. It expresses respect for the patient's right to make medical decisions and a caring relationship with healthcare providers. Informed consent enables patients to become actively involved in their care, and ACOG emphasizes that communication is a bedrock of informed consent, and that it requires an environment that fosters and facilitates communication. ACOG also emphasizes that informed consent is an information sharing process that occurs over time. It is not just obtaining a signature on a form. Informed consent involves respect for the whole patient and takes into account circumstances in which surrogate informed consent may be required or emergencies when consent cannot be obtained. And finally, ACOG emphasizes that informed consent incorporates ethics principles as well as state and federal legal requirements and institutional policy. Moving to slide 13, we see a list of the top 5 obstetrics-related incidents for health centers and clinics by cause of occurrence. They include improper management, improper performance of vaginal delivery, improper choice of delivery, delay in performance, and failure to identify fetal distress. But it should be noted that a category of other actually ranked 4th in cause of occurrence. On slide 14, we note that training and lack of supervision are secondary factors in Federal Tort Claims Act covered incidents reviewed by KEPRO, and they assume dominance during the fiscal year 2009. Training needs repeatedly identified included many related to obstetrics, such as electronic fetal monitoring, shoulder dystocia, and preeclampsia. Communication issues were also among the top secondary factors identified by KEPRO in medical malpractice incidence claims for year 2009 and 10 involving HRSA, Federal Tort Claims Act health centers, and free clinics. Over the next several slides, we'll review a report of a malpractice case involving a delay in responding to fetal distress. As we go through the reported facts as they occurred, please try to spot the patient safety and risk issues. The patient was an obese woman, para 4, pregnancy-induced hypertension controlled with atenolol, and gestational diabetes. She was admitted at 3 centimeters, 50% effaced, -4 station. The fetus was transverse lie. The fetal heart rate ranged between 130 and 140. An epidural was administered. The fetus was in vertex position, and after the amniotic fluid was ruptured, it was clear. A scalp electrode was placed. At 12:30 p.m., the fetal heart rate was 70. A scalp pH was ordered. The attending obstetrician decided on a cesarean section. At 12:40 p.m., the fetal heart rate ranged between 110 and 120. With scalp stimulation, it ranged between 130 and 140, and so the obstetrician canceled the cesarean section. At the same time, the mother was 6 to 7 centimeters, 75% effaced, and the fetus was -3 station. Moving to slide 16, at 1 p.m., the fetal heart rate dropped. A cesarean section was reordered. The fetal heart rate recovered, and the cesarean section was canceled. Between 1 and 3 p.m., the fetal heart rate was shown to have increased, but there were variable decelerations. The patient was repositioned. The obstetrician was notified. The nurse was worried, informed the head nurse, who conferred with the attending. At 4 p.m., the fetal baseline was 180. At 4:20, the fetal heart rate dropped to the 90s. There were variable decelerations. The attending tried to get a scalp pH while the fetal heart rate was dropping with recurring deep decelerations. The attending was unsuccessful. The RN paged another obstetrician, but he or she was unavailable. And on slide 17, at 4:45 p.m., the mother was fully dilated. The scalp pH showed severe acidosis. The patient was taken immediately to the OR for vaginal delivery. The attending believed that vaginal delivery would be faster than a cesarean section, but declined vacuum assist. Vaginal delivery occurred. There was a tight double nuchal cord. APGARs were 1, 3, and 5. The pediatric resident transferred the infant to the ICU. The blood cord pH was 6.86. Metabolic acidosis, hypoxemia, and DIC was diagnosed. And on the 5th day of the infant's life support was removed. On review, the case was found to have met ACOG's criteria for acute intrapartum hypoxic event, and an autopsy was normal in the sense that there were no genetic abnormalities. The conclusions reached from the claims analysis was that the attending obstetrician demonstrated inexperience and indecision, that he lacked confidence in his knowledge of a concerning fetal heart pattern, and backed off a plan for cesarean section. The obstetrician failed to consult a more experienced obstetrician in the face of his own uncertainty. The attending obstetrician did not appreciate the patient's medical history, which may have been a contributing factor to the adverse outcome. The attending also met the patient for the first time on the day of labor and delivery. Communication among the obstetrical team broke down and may have resulted in delayed response to fetal distress because of inability to resolve the differences and failure to seek a consultation. Although the obstetrics nurse did speak with her supervisor about her concerns, the nurse's discomfort was not resolved because her supervisor did not continue the chain of command until the concerning issues were appropriately resolved. The end result was the birth of an infant whose adverse outcome met ACOG's criteria for acute intrapartum hypoxic event. We now have reviewed the highest risk areas for obstetrical practice and identified contributing factors through malpractice claims reviews. In the next part of this program, Kathy will discuss strategies for reducing these risks and improving patient safety. But before I hand over the program to Kathy, Kathy will conduct our first polling question to gauge what levels of obstetrical care participants in today's program are providing.
Thank you, Madeline. Please listen to the following instructions with regards to our polling question. If your health center directly provides pre- and or postnatal care, please press star 1. So if your health center provides prenatal care and postnatal care, or either prenatal care or postnatal care only, please press star 1. If your health center directly provides complete obstetrical care through labor and delivery, please press star 2. And if your health center does not provide direct prenatal care or postnatal care, or does not provide either, please press star 3. Thank you for taking the time for our poll. We are now on slide 19, which summarizes the 5 key principles forming the foundation of the redesigned patient safety process implemented over the past decade by the Nashville, Tennessee-based Hospital Corporation of America. These strategies include standardizing processes and procedures, for example, using perinatal care bundles for oxytocin induction and augmentation of labor, creating a culture of safety. This includes improving communication and teamwork and empowering team members to intervene anytime patient safety is jeopardized. This topic is covered in detail in the Clinical Risk Management Basics audio conference, which is archived on the website. Viewing cesarean delivery as a process alternative and not an outcome or a quality endpoint. Despite evidence that a cesarean section rate of 5 to 10% would be optimal in reducing the risks inherent with more invasive surgical deliveries, and that rates approaching 15% may have aggregate harm to a population, the current national cesarean section rate in the United States is over 30%. Reasons given for this steady and alarming increase over the past decade are numerous, but they include side effects from common labor interventions, such as elective induction for a nulliparous woman with an unfavorable cervix, providers or facilities unwilling or unable to offer a vaginal birth after a cesarean due to liability concerns, or obstetrical coverage shortfalls, and a limited awareness in general that harms are more likely with cesarean sections. While time does not allow a discussion of vaginal birth after cesarean per se, I would mention that ACOG, in consideration of the 2010 National Institute of Health report on vaginal birth after cesarean and a review of the scientific evidence, has just released an updated practice bulletin on the topic, published in the August 2010 issue of Obstetrics and Gynecology. The next strategy is using unambiguous practice guidelines. For example, having 24-hour hospital obstetric coverage and physician availability at the bedside within 5 minutes during vaginal birth after cesarean section. And the last strategy, but certainly not the least, is conducting effective peer review based on perinatal quality and risk indicators. Use of these redesigned patient safety processes for obstetrical care by HCA has been associated with improved perinatal outcomes, a reduced primary cesarean delivery rate, and lower maternal and fetal injury with reduced litigation as evidenced by a reduction in the number of claims by 1/2 and a nearly 5-fold reduction in the cost of claims. HCA is not alone in its success. A number of other organizations and cooperative initiatives to improve perinatal safety and reduce liability risk have also seen positive accomplishments. Over the next several slides, we'll review some of these specific strategies. Slide 20 contains examples of successful uniform processes for obstetrical care. In the practice of obstetrics, process standardization helps to ensure that all caregivers on the team know what the attending provider is expecting and what the other team members' roles are. Perinatal care bundles are defined as a group of evidence-based interventions that, when executed together, result in better outcomes than when implemented individually. The all or none feature is the source of the bundle's power. On slide 21 are 2 care bundles that were implemented as part of an innovative perinatal improvement project by Premier, Ascension Health, and the Institute for Healthcare Improvement. The group first reported on their project in a white paper called The Idealized Design of Perinatal Care. Among the key components of this project are reliable processes to evaluate and manage labor and delivery using these perinatal bundles. The bundles summarized here are aimed at improving the use of oxytocin, a commonly used high-risk drug. Many malpractice cases against obstetricians allege misuse or overuse of oxytocin. Oxytocin was the #1 drug among the top 10 medications involved in wrong dose and overdose errors in the labor and delivery unit, reported by the Pennsylvania Patient Safety Authority in its advisory on medication errors in labor and delivery. A guidance article based on this advisory is available at the Clinical Risk Management website. The American Congress of Obstetricians and Gynecologists and the Association of Women's Health, Obstetric, and Neonatal Nurses, or AWON, accept the definitions of fetal monitoring by the National Institute for Child Health and Human Development, or I'll call NICHD. Use of these definitions provides a standard terminology to describe fetal heart rate monitoring, as well as a plan of action to ensure compliance with elements of these perinatal bundles. Documented pelvic examination to determine fetal presentation is part of both bundles, as is acceptance of the NICHD definitions and nomenclature for uterine activity. Important to the success of this perinatal improvement project is the use of the same validation tool for interpretation of the fetal heart rate among obstetric providers and nurses. When all members of the labor and delivery management team understand each other and can communicate effectively, patient safety is enhanced and risk of communication failure is reduced. Slide 22 lists references with sample protocols and checklists and documentation forms. To guarantee that all elements of the bundles are dependably addressed and ensure the safest use of oxytocin and other drugs, the use of standardized order sets and documentation forms with checkboxes and fill-in blanks are advocated. These checklists and forms are meant to serve as forcing functions aimed at making it easy to do the right thing. On slide 23, we see the components of another successful patient safety strategy focused on obstetrical care. This multifaceted approach was used to improve safety and reduce the rate of adverse outcomes in obstetrics by the Yale New Haven Hospital in partnership with its medical malpractice carrier. Goals were to decrease injury as well as liability losses by creating a culture of safety and initiating specific risk reduction practices. Listed here on the slide are the elements of the program. Yale began with a review of their obstetrical services by outside expert consultants. These yielded recommendations for improvement. They developed a series of protocols and guidelines delineating practice standards. A patient safety nurse position was created to evaluate clinical care and outcomes, activate an anonymous event reporting system and database, initiate team training, and electronic fetal monitoring certification. An obstetrical patient safety committee was formed to define and track adverse events and address the need for protocols. An assessment of the safety culture was undertaken, followed by teamwork training as a condition for employment or clinical privileges. Electronic fetal monitoring certification that incorporated the NICHD guidelines and culminating in an examination was implemented, and all providers and staff responsible for fetal monitoring were obliged to take the exam. Effectiveness of these initiatives was gauged in part by the use of a quarterly composite adverse event rate, expressed as the number of deliveries, or mothers, with associated adverse events per total deliveries for each 3-month period. On slide 24 is a line chart approximating Yale's 3-year trend in the Adverse Outcome Index, defined as the number of deliveries with one or more identified adverse events as a proportion of total deliveries. The types of adverse events included in the analysis are listed in the left-hand corner of the slide. The downward slope of the line is indicative of the progressive effectiveness of the obstetric patient safety strategies in reducing the Adverse Outcome Index. Other aspects of care were also monitored, and these included the cesarean delivery and episiotomy rates, occurrences of shoulder dystocia, and changes in the safety culture and electronic fetal monitoring training results. During the course of the project, perceptions among nurses and physicians of a good teamwork climate improved from 16 to 89% and from 40 to 72% respectively. We now turn our attention to operative vaginal deliveries, and slide 25 lists the Institute for Healthcare Improvements vacuum delivery bundle. It begins with requiring that consideration be given to other delivery alternatives. Serious complication of vacuum deliveries occur in approximately 5% of vacuum attempts. Patients need to be aware of these risks, and therefore informed consent should be obtained and documented. Because trauma associated with operative vaginal deliveries are varied, it must be ensured that forceps and vacuum extractors are used according to ACOG guidelines. Operative vaginal delivery becomes a high-risk procedure when there is a low chance of success, when the provider uses a trial of operative vacuum delivery, uses a combination procedure with forceps, and when the gestational age is less than 34 weeks. According to experts writing in the literature, for a safe vacuum-assisted vaginal delivery, the most important thing is to obtain a proper application. Estimated fetal weight is critical to the procedural risks, and station and position of the fetus must be known. Because cephalohematoma is directly correlated with application time and multiple pop-offs are associated with cephalopelvic disproportion, fetal injury, and failed procedure, application time and maximum number of pop-offs should be predetermined by protocols. And in the case of failure, alternative delivery options such as cesarean section should be readily available. Slide 26 lists a protocol for instrumented deliveries, another term for operative vaginal deliveries. As part of Ascension Health's National Perinatal Safety Program, the Seton family of hospitals implemented transformational practices in labor and delivery aimed at reducing the rate of birth trauma in their facilities. Participating facilities created systems to ensure that evidence-based practices were reliably followed for high-risk conditions associated with perinatal harm, that robust strategies for communication were adopted, and that collaborative practice was promoted among caregivers. At the end of a 3-year period, all facilities achieved birth trauma rates that were at or near zero with the implementation of these practices. Using the instrumented delivery protocol in conjunction with other perinatal safety initiatives, the Seton hospitals first reported in 2007 a reduction in the use of vacuum in forceps from a frequency of 7.4 to 4.7%, and subsequently reported that the use continued to decline to a rate of 4.1%. The incidence of birth trauma associated with the use of these devices also decreased. Most significantly, Seton reported that there were no occurrences of birth trauma associated with instrumented delivery for 15 consecutive months. Slide 27 lists risk reduction strategies, specifically for vacuum-assisted delivery, and they indicate that residency training should be supplemented with formal mentoring programs, and proper credentialing of providers is a must. Policies should be established that specify parameters such as indications and contraindications for vacuum-assisted delivery, total time of procedure, maximum time and pressure of vacuum use, and maximum number of pop-offs. It is important to practice teamwork drills to refine effective communication of the parameters. Standardized documentation of vacuum-assisted vaginal deliveries is recommended, and audits should be implemented to audit the care unit as well as individual obstetrical providers. Slide 28 addresses documentation. It is important to document the indication for instrumented delivery, position and station of the fetal head, and how it was assessed, vaginally or abdominally, assessment of maternal pelvis, ease and application of vacuum and placement position, duration of traction and force used, and description of any maternal or neonatal injuries, and of course, the informed consent process. For more information on this, log on to the Clinical Risk Management website and access the guidance article called Preventing Maternal and Neonatal Harm During Vacuum-Assisted Vaginal Delivery. Slide 29 begins our review of shoulder dystocia. Shoulder dystocia is the fourth most common cause of medical litigation involving delivering providers and accounts for 11% of all obstetrics-related lawsuits. The causes are mechanical and associated with impaction of the anterior fetal shoulder behind the maternal pubis symphysis, or impaction of the posterior fetal shoulder on the sacral promontory, or impaction of both, which results in the fetal head being delivered while the shoulders are impacted. Shoulder dystocia may result from the failure to deliver the fetal shoulder without using external or internal maneuvers. There is a subjective component of this diagnosis that requires internal and/or external maneuver determination by the delivery provider. Moving to slide 30, we see that for a 4-year period, the Pennsylvania Patient Safety Authority received 316 reports involving shoulder dystocia. In 124, or 39% of them, neonatal injuries, including fractures and brachial plexus injuries, were identified, as well as fetal death. Several of the facilities reported that shoulder dystocia events through the system identified contributing risk factors that led to the injuries sustained during antepartum care, intrapartum care, and at delivery. Risk factors for shoulder dystocia are noted on slide 31. Maternal risk factors for shoulder dystocia include gestational diabetes, obesity, and post-term pregnancy. Intrapartum risk factors for shoulder dystocia include instrumented assisted vaginal delivery using forceps or vacuum, precipitous or protracted second-stage labor, and delayed head-to-body delivery time. Specific fetal factors for increased risk of shoulder dystocia include macrosomia, large chest, or biparietal diameter, and the fetal shoulders remaining in the anterior-posterior plane. Fetal manipulation can be reasonably used during shoulder dystocia deliveries, but it is important for birthing providers to be aware of the natural tendency to apply traction when faced with a difficult delivery. Increasing clinically applied traction to the head during the birth process may produce stretch injuries of the fetal's brachial plexus. The extent of nerve injury depends on the magnitude and direction of the delivery force, as well as the rate at which it is applied. Prolonged labor and the use of forceps or vacuum extraction are associated with an increased risk for shoulder dystocia, although the risk is significantly greater with vacuum extraction. There are no evidence-based guidelines for the prediction, prevention, or management of shoulder dystocia. The current practice guidelines are based on limited scientific evidence and the consensus opinions of experts. ACOG developed guidelines to aid obstetric practitioners in making decisions about appropriate care. Most cases of shoulder dystocia cannot be predicted or prevented because there is no accurate method to identify fetuses that will develop the complication. That being said, and as indicated on slide 32, shoulder dystocia risk management involves identification and communication of patients at risk before delivery, management of shoulder dystocia occurs to minimize potential injury to the fetus and the mother, thorough documentation and treatment upon discovery of the problem, and ongoing interdisciplinary simulation drills for all obstetric staff that include the application of external and/or internal maneuvers. On slide 33, we see that clinical risk management of shoulder dystocia begins with the recognition of risk factors. A thorough patient history should be obtained during the part of antenatal care. Noting the birth weight of the mother's other infants in the case of multiparity is important because subsequent births can result in shoulder dystocia. Prenatal laboratories and diagnostic studies include glucose screening. Any history of maternal diabetes may also indicate propensity. Documentation of estimated fetal weight is very important despite the controversy and margin of error because the failure to assess and document fetal weight during pregnancy or labor may constitute a deviation from the standards of practice. Communicating any suspicion of fetal macrosomia will help the delivery team to collaborate and plan for the management of such an emergency. A number of maneuvers are available for the relief of shoulder dystocia, and the order of them is not as important as their effective and appropriate use. Descriptions of the maneuvers are included in the guidance article, Neonatal Complications, Recognition and Prompt Treatment of Shoulder Dystocia, along with documentation suggestions for their resolution. This is available at the Clinical Risk Management website. It is important to provide factual information and consistently document any episode of shoulder dystocia. The information on slide 34 is useful to document when encountering a delivery complicated by shoulder dystocia for retrospective review. This list is included in the guidance article previously mentioned. Slide 35 summarizes communication and information flow, the effectiveness of which is to improve obstetrical safety and reduce the risk of liability. Inadequate communication among providers regarding the plan of care for a patient is a common path for substandard care. In the office setting, protocols should be in place so that there is consistent delivery of care across all providers and all types of clinical problems. It is also important to communicate clearly that all administrative delays, such as lack of availability of a timely diagnostic test, faulty equipment, or insurance delays for pre-authorization, are brought to the attention of the practice manager to avoid unnecessary delays in patient treatment. Covering providers need some process to gain an understanding of the patient's history, status, and any aspects that may place the patient at increased risk. Whenever possible, ensure that patients rotate through your health center and see all providers that could be involved in their delivery. Being the attending obstetrical provider who meets a patient with a complicated obstetrical history and numerous health issues on the day she is admitted to labor and delivery is very risky. If a different team of providers will be delivering the patient, clinical risk management demands a fail-safe means of communicating patient information among prenatal, labor delivery, and postnatal providers. It's also important to develop a mechanism to ensure that obstetrical records are transported to the hospital or birth center by the 36th week of gestation. Prenatal care can lead to care by many providers at several locations, such as offices or clinics, hospitals, or emergency rooms. It's important to ensure that there is a way to address updated information and transfer that information to the record. There are a number of resources on communication available at the Clinical Risk Management website. Slide 36 includes additional resources available at the website. Before I hand the program back to Amy, we'll conduct a second polling question just to gauge the number of participants at each registered site. Operator?
Thank you. We will now begin the second polling question. After each question is asked, please respond by pressing star, followed by the appropriate digit on your phone. You will hear a tone upon making your selection. How many people are in the room? Please press star 1 for one person, star 2 for 2 people, star 3 for 3 people, star 4 for 4 people, star 5 for 5 people, star 6 for 6 people, star 7 for 7 people, star 8 for 8 people, and star 9 for 9 or more.
Okay, thank you very much. At this point, we're going to open up the phone lines for questions. And thank you very much for joining us.
Thank you. We will now begin the question and answer session. If you would like to ask a question, please press star 1. Please unmute your phone and record your name clearly when prompted. To withdraw your request, press star 2. One moment, please, for the first question. We have no questions at this time.
Okay, if we have no questions, then we will conclude. Barbara, do you have any closing comments, or should we conclude?
Yes. I just want to say on behalf of HRSA, I want to thank our partners, KeyPro and the ECRI Institute speakers for the information they have provided on this timely topic. And I'd like to thank all of the participants on the line today and our operator.
Thank you very much, everyone.
Thank you for joining today's conference. You may disconnect at this time.